Welcome back everyone. My today's lesson is about Duchene and the Becker muscular dystrophy. The term dystrophy is a Greek word which means abnormal growth. A muscular dystrophy is a group of disorders which are distinguished from all other neuromuscular diseases by four obligatory criteria. Those criteria include it is a primary myopathy, it has a genetic basis, the course is progressive, and degeneration and the death of muscle fibers occur at some stage in the disease. This definition excludes neurogenic diseases such as spinal muscular atrophy, non-hereditary myopathies such as dermatomyositis, non-progressive and non-necrotizing congenital myopathies such as congenital muscle fiber type disproportionation, non-progressive hereditary metabolic myopathy. As I said above, muscular dystrophy is a group of disorders with similar expressions, but the most common one is dystrophinopathies. Those are Duchenne and the Becker's muscular dystrophy. Duchenne muscular dystrophy is the most common hereditary neuromuscular disease affecting all races and ethnic groups. It is characterized by those clinical features. Those are progressive weakness, intellectual impairment, hypertrophy of the pelvis with proliferation of connective tissue, progressive fibrosis in muscles. The incidence is 1 in 3,600 live-born infant boys, and this disease is inherited as X-linked recessive trait. The abnormal gene is located on X chromosome, on the short arm of X chromosome at 21 locus, and this is one of the largest genes. Becker muscular dystrophy is a disease that is fundamentally similar to Duchenne muscular dystrophy, with a genetic basis at the same locus, but clinically it follows a milder and a more protracted course. When we see the clinical manifestation of Duchenne muscular dystrophy, infants with Duchenne muscular dystrophies are rarely symptomatic at birth or in early infancy, although some are mildly hypotonic. Early gross motor skills such as rolling over, sitting, standing are usually achieved at the appropriate age. Walking is often accomplished at the normal age of approximately 12 months, but hip girdle weakness might be seen in subtle form as early as 2 years of age. Toddlers might assume a lordotic posture when standing to compensate for gluteal weakness. An early goer sign, it might be seen at the age of 3 years, but nearly always it is evident by age of 5 to 6 years. This is an image of a child with goer sign. They can't stand up from sitting position directly. They climb up through their extremities because of proximal muscle weakness. A Trendelberg gait or a waddling gait is frequently seen, and it appears at this time as well, around 3 to 4 years of age. And the common presentation in toddlers include delayed walking, frequent falling, toe walking, trouble running or walking upstairs, and the developmental delay, and the less often malignant hyperthermia after anesthesia. The age of complete loss of ambulation ranges typically from about 10 to 14 years. The age at which loss of independent ambulation occurs has increased over time with the advent of use of corticosteroids, orthotic bracing, physiotherapy, and some minor surgeries such as Achilles tendon lengthening. Most are able to walk until age 12 years. Maintenance of ambulation is not only important for preservation of autonomy in activities of daily living, but also provides additional benefits in slowing the progression of scoliosis that typically worsens after loss of ambulation and in maintenance of pulmonary health. The relentless progression of weakness continues into the second decade. The function of distal muscle is usually relatively well enough preserved, allowing the child to continue to use eating utensils, pencil, and the computer keyboard. As the disease progresses in the teenage years, the upper extremity strength declines further, and the patient might have increased difficulties bringing hands to mouth independently, and the fatigue with writing, worsening contractures, including the hands and the fingers. Respiratory muscle involvement frequently manifests as a weak and ineffective cough, frequent pulmonary infection, and the decreasing respiratory reserve. Early pulmonary symptoms often include snoring and sleep apnea, and pharyngeal weakness can lead to episodes of aspiration, nasal regurgitation of liquids, and airy or nasal voice quality. The function of the extraocular muscles remain well preserved, and incontinence due to anal and urethral sphincters weakness is uncommon and a very late event. Contractures most often involve the ankles, knees, hips, and the elbows. As upper extremity weakness progresses, contractures are also seen in the neck lateral rotation, shoulders, and the fingers. Scoliosis is common in patients with muscular dystrophies, and the thoracic deformity further compromises the pulmonary capacity and compresses the heart, and it may also lead to more discomfort and, if severe enough, risk for hip dislocation. Scoliosis usually progresses more rapidly after the child becomes non-ambulatory, and enlargement of the calves or pseudohypertrophy and the wasting of the thigh muscles are classic features, and it is caused by hypertrophy of some muscle fibers, infiltration of muscles by fat, and proliferation of collagen. After the pelvis, the next most common site of muscular hypertrophy is the tongue. This is followed by muscles of the forearm. Fasciculations of the tongue do not occur, and the voluntary sphincter muscles rarely become involved. Unless ankle contractures are severe, ankle deep tender reflex remain well preserved until terminal stage, and the knee deep tender reflex might be present until about 6 years of age, but they are less brisky than the ankle jerks, and they are eventually lost with the progression of weakness. In the upper extremities, the brachioradialis reflex is usually stronger than the biceps or triceps brachyreflexes, and cardiomyopathy, including persistent tachycardia, myocardial fibrosis, and the cardiomyopathy occurs in a majority of patients with Duchenne muscular dystrophies. The severity of cardiac involvement does not necessarily correlate with the degree of skeletal muscle weakness. In a patient with Duchenne muscular dystrophy, the progression of cardiomyopathy typically occurs after loss of independent ambulation. However, in a patient with Becker's muscular dystrophy, patient may develop worsening of cardiomyopathy and even develop severe heart failure despite still being ambulant. Smooth muscle dysfunction, particularly of the gastrointestinal tract, is a minor but often overlooked feature. Intellectual impairment occurs in a majority of patients, but only 20 to 30% have an IQ less than 17. The extent of severity of the intellectual disability does not appear to correlate with the severity of the myopathy, but might be related to the location of the mutations in the dystrophin gene. Epilepsy is slightly more common than in the general pediatric population, and dystrophin is expressed in brain and retina as well as in striated in the cardiac muscle, though the level is lower in brain than in muscles. This distribution might explain some of the central nervous system manifestation. Deaths in boys with Duchenne muscular dystrophy occurs in the late 10s to 20s, and the cause of death are respiratory failure during sleep, and also intractable heart failure, pneumonia, or occasionally aspirations and airway obstruction. In Becker's muscular dystrophy, the onset is often after 5 or 7 years of age, and the boys remain ambulatory until late adolescence or even well until adulthood. Calf muscle hypertrophy or pseudohypertrophy of calf muscle, cardiomyopathy, and elevated CK are similar to those of patients with Duchenne muscular dystrophy. And learning disabilities are less common, and the onset of weakness is later in Becker's muscular dystrophy than in the Duchenne. The lifespan in patients with Becker muscular dystrophy is typically into the 14s and the 15s. When we see laboratory findings, the serum CK level is consistently greatly elevated in Duchenne muscular dystrophy, even in pre-symptomatic stages, including at birth. The usual serum concentration is around 50,000 to 35,000, whereas the normal one is less than 160. A normal serum CK level is incompatible with the diagnosis of Duchenne muscular dystrophy. Although in terminal stage of the disease, the serum CK value might be considerably lower than it was a few years earlier because there is less muscle to degenerate. And cardiac assessment by echocardiography and ECG are essential, and they should be monitored. The recommendation is for cardiac surveillance every other year starting at the time of diagnosis, and then yearly when the child demonstrates cardiac manifestation or when the child reaches around the age of 10 years. Electromyography shows characteristic myopathic features but it's not specific for DMD, and no evidence of denervation is found, and motor and sensory nerve conduction velocities are normal. When we see the diagnosis of Duchenne and Becker muscular dystrophy, genetic evaluation for Duchenne muscular dystrophy typically begins with deletion and the duplication analysis of the dystrophin gene using dosage analysis. If negative, then sequencing of dystrophin gene by next generation sequencing is performed. And if genetic analysis is still negative for mutations in dystrophin gene, but if the suspicion is high based on clinical features and the serum CK level, then muscle biopsy with dystrophin immunohistochemistry might be useful. The muscle biopsy is diagnostic and it shows characteristic changes. And if there is a family history of the disease, particularly in the case of an involved brother whose diagnosis has been confirmed, a patient with typical clinical features of Duchenne muscular dystrophy and high concentration of serum CK probably does not need to undergo muscle biopsy. The result of genetic testing, which might also influence whether to perform a muscle biopsy. A first case in the family, even if the clinical features are typical, should have the diagnostic confirmed to ensure that another myopathy is not miscoding as Duchenne muscular dystrophy. The most common muscle samples are taken from vastus lateralis and the gastrocnemius. When we see genetic etiology and the pathogenesis, despite the X-linked recessive inheritance in Duchenne muscular dystrophy, approximately 30% of cases are new or de novo mutations and the mother is not a carrier. The female carrier state usually shows no muscle weakness, but due to skewed X inactivation, about 8% of carrier females are manifesting carriers with some weakness, although typical milder than that in the affected males. The symptomatic females are explained by the Lion hypothesis, in which the normal X chromosome becomes inactivated and the one with the gene deletion is active. The full clinical pictures of Duchenne muscular dystrophy has occurred in several females with Turner syndrome, in which the single X chromosome must have the short arm of X chromosome gene deletion. Approximately 40% of female carriers might be at risk of developing cardiomyopathy or fibrosis, even in the absence of skeletal muscle weakness. Regarding treatment of Duchenne and Beckers muscular dystrophy, there is no medical cure for this disease at this time, so the mainstay of management is supportive and preventive care so far. Glucocorticoids have been shown to slow the decline in muscle strength and increase the time a patient maintains independent ambulation, and it might have additional benefit on scoliosis progression. Initiation of steroids is indicated when a child shows a plateau in development and or regression in motor development as compared with peers. This typically occurs by 4 to 6 years of age, and the recommended dose of prednisolone is around 0.75 mg per kg per day. Cardiac care initially includes AC inhibitors or angiotensin receptor blockers or beta blockers or aldosterone antagonists, and most cardiac treatments are initiated at the time of drop in the left ventricular ejection fraction to less than 55% at most centers, whereas some advocate for initiation of treatment before the echocardiogram abnormalities are detected. Due to potential risk for hyperkalemic or malignant hyperthermia reactions to anesthesia, it is recommended to avoid agents such as inhaled anesthetics or muscle relaxants. And pulmonary infection should be promptly treated, and the patients should avoid contact with children who have obvious respiratory or other contagious illness. And immunization for influenza virus and other routine vaccinations are indicated. When sleep disorder breathing is suspected, children should have to undergo sleep studies, and the use of BiPAP should be considered. And additionally, cough assist device, proper sanctioning of secretion, and nebulized therapies may assist airway clearance as children develop weakness in coughing. Preservation of a good nutritional state is important. Adequate calcium intake is important to minimize osteoporosis in boys confined to a wheelchair. Because of the decreased caloric expenditure in non-ambulant children and also the use of corticosteroids, which increase appetite, these children tend to eat excessively and gain weight. Obesity makes a patient with myopathy even less functional because part of the limited reserve of muscle strength is dissipated in lifting the weight of excess subcutaneous adipose tissue, so dietary restrictions with supervisions might be needed. Regarding physiotherapy delays but does not always prevent contracture. At times, contractures are actually useful in functional rehabilitation. If contracture prevents extensions of elbow beyond 90 degrees and the muscles of upper limb no longer are strong enough to overcome gravity, the elbow contractures are functionally beneficial in fixing an otherwise flail arm and in allowing the patient to eat and write. Surgical corrections of elbow contracture might be technically feasible, but the result might be deleterious. Stretching and bracing methods might be useful depending on the location of the contracture and the level of severity of the contracture. Physiotherapy contributes little to muscle strengthening because patients usually are already using their entire reserve for daily functioning, and exercise cannot further strengthen involved muscle. Excessive exercise can actually accelerate the process of muscle fiber degeneration, so excessive exercise is not recommended for patients with muscular dystrophies. This is all about what I have for Becker's and Duchenne's muscular dystrophy. Thank you for your attention.